Hello and welcome to SCAN. I'm your host Tracy Wolfman, and today we have a very special guest, Dr. Patel, who is the Medical Director of the Department of Oncology at Riverview Medical Center. Welcome to our show today, Dr. Patel.
Thank you for having me.
You're welcome. Anyway, we're going to talk about a great topic today, so I hope all you viewers out there are going to be taking notes on this topic that Dr. Patel is going to talk to us today about. And we're going to talk about what is prostate cancer, some of the treatments for prostate cancer, CyberKnife, and how we navigate this.
Absolutely.
So welcome. I just want to tell our viewers a little bit about you, that you graduated from NYU University with a Bachelor's of Science degree in honors in neuroscience. Dr. Patel subsequently attended UMDNJ New Jersey Medical School, where she received her medical degree, and she has affiliations with Hackensack Meridian Health, which she began an internal medicine internship at Jersey Shore Medical Center right here in our Monmouth County. Then she went on to complete her radiation oncology residency at Stitch Radiation Arnold Center at New York Presbyterian Hospital, Weill Cornell Medical Center, and New York Hospital, Queens. And you were the chief resident. That's a big title.
Thank you.
She has since been practicing at Riverview Medical Center as medical director of the radiation oncology. Dr. Patel has presented research about breast, gynecological, prostate, CNS, and lung malignancies at national scientific meetings and has authored several journal articles and book chapters. Her expertise includes stereotactic radiosurgery. She is active member of ASTRO, ACRO, and the NYU Metropolitan Breast Cancer Center. And you live in Colts Neck, so you're a Monmouth County resident and have 3 children. That's awesome that you're here today and local in our community with all this expertise.
Thank you.
So we're happy to have you and to educate us and our viewers watching us today about what is prostate cancer.
So the prostate gland actually is a gland that normally helps with semen production, and it is typically the size of a walnut, and it is located just below the bladder and in front of the rectum. And sometimes these prostate gland cells start rapidly producing, and that's what a cancer cell is. It's the growth of abnormal cells. Okay, and so it's typically tested by either a digital rectal exam by your primary care physician or urologist, or by a blood test with something called a PSA.
The PSA test that everyone talks about all the time, right?
Yes. So the age to start screening for prostate cancer typically depends on your family history.
Okay.
So if typically around age 50 is when a patient would get either a digital rectal exam by their primary care doctor or get blood work done for a PSA. The PSA basically is a protein that's expressed from the prostate, and men normally have a PSA expressed from their prostate,
Right.
but when the levels go above 4, typically, then we start wondering if there's a potential malignancy starting.
It's interesting how people like the 60 to 80-year-olds, because I deal a lot with them, you know, they're always talking about their PSA number.
Yes.
And it's funny how they know it.
Yes, absolutely. And, you know, interestingly, as we age and as the prostate size enlarges, the PSA can go higher, but it doesn't necessarily mean that it's cancer there. So
That's a good thing for our viewers to know.
There are other reasons that can falsely elevate a PSA. If they've been very active, riding a bicycle, even sexual activity or an infection, prostatitis or urinary tract infection, those are all things that could falsely elevate a PSA. So a lot of the times their primary care doctor or urologist may just repeat the PSA to see if there's a trend. And if the trend persistently stays elevated, then they may go further into trying to figure out what exactly is going on. In terms of when to start PSA screening.
Yeah, I think our viewers would be very interested to know when they should start the PSA. So you said family history is one.
Yes.
And
so typically it's age 50. But if they have a family member, like a brother or a father that was diagnosed with prostate cancer maybe earlier in life, then it may be good to start testing 10 years before their diagnosis. So if someone's father was diagnosed at age 55, then maybe they should start at 45. And also, lastly, African Americans tend to get diagnosed. They should get also screened at an earlier age also.
Okay, that's good information for our viewers to know. One thing, what about the symptoms that people ignore that
Yes.
could be a precursor for prostate screening?
It's a very good question. So actually, prostate cancer is typically asymptomatic, and a lot of symptoms that men feel is just usually from an enlarged prostate gland. So just how women
Also
have
depression.
different breast sizes, men can have different prostate sizes.
Okay.
And so when the prostate starts enlarging, which typically happens as men age, as the prostate starts enlarging, it almost puts pressure on the bladder because it sits right underneath it.
Okay, that makes sense.
And as it enlarges, then men may notice increased urinary symptoms like frequency or urgency or getting up more at night. And that's more related to the size of the prostate rather than having symptoms from a prostate cancer.
That's great information for our viewers to know, because I think a lot of people, when they think of prostate and they think of those numbers and they've read about the symptoms, because it's always in the news.
Yes,
Do
absolutely.
you get tested? Do you not get tested? Is our health insurance going to allow us to get tested?
Yes.
Same with everything else they're cutting, right? So you said around 50, if you're African American, you should get tested earlier than that, and or if you have a family history.
Yes.
So we want our viewers to know those three important factors. Can you tell them a little bit about how the PSA screening is done? I mean, you said the
Yes. So we talked
internists
about
could
that.
do it, or
Yes, internists can do it, a urologist can do it. And then you had asked a great question before about, at what age should people stop PSA screening possibly? And I think it depends on the patient's health. And, I have men in their 70s that frequently get PSA screening with a blood test.
Okay.
And it depends on their overall health. If a man has multiple health issues in their 70s, then PSA screening may not be as important because they have other issues going on. And prostate cancer, believe it or not, most men don't die from prostate cancer.
right, which is a great thing.
Yes, so diagnosing it later in life may not be as critical. However, if they're symptomatic or they are relatively healthy, I think it would be important to continue screening into their 70s.
And get them some relief if they are having
Yes.
symptoms that are. So why don't we talk a little bit now that we know that how they can get diagnosed, how they should get checked, what ages. What are some of the treatment options? Because people typically, and you just kind of referred to that, have good outcomes with this.
Yes, absolutely. So if a patient has an elevated PSA or they have an abnormal exam by a physician, the next step would be to do a biopsy.
Okay.
And
Is that painful?
so it's typically done either under local or light sedation
Okay.
by your urologist. And what they would do is they basically will sample the prostate. They put needles, like maybe anywhere from 12 to 20 needles within various areas of the prostate. And that
Into that small walnut
Into that
shape?
small walnut shape.
I guess it's going to kind of look like acupuncture.
Yes, exactly.
Okay.
And it's typically done with an ultrasound that's helping guide them. Okay.
very
And so an ultrasound is used, and they biopsy the prostate, and sometimes they may detect an abnormality by either an exam, or the patients can also get an MRI done, which helps guide the urologist on which areas to biopsy.
Okay.
So an MRI is another study that can be ordered.
MRI of the prostate.
Yes, an
Haven't
MRI.
heard about that one.
Yes.
That's-
So an MRI of the prostate can be done, and biopsies can be done. Those are the two ways that we actually will kind of look for a cancer once their suspicion is there that we should check.
So they go for their PSA testing. They have 2 or more elevations because you're going to watch the first one.
Exactly.
And then they're going to go for the biopsy.
Yes, and if it's abnormal, they'll get a biopsy and or an MRI to help guide the physician on where to focus on if there is an abnormality seen on the MRI or felt on an exam. And so a biopsy is done, and so their treatment options will depend on the results of the biopsy.
Okay.
So when a patient is diagnosed with the prostate cancer, we try to stratify their risk. Are they low risk, intermediate risk, or high risk?
Okay.
And those 3 risk definitions will define which pathway they will go for their treatment options.
Oh, very interesting.
So when someone has a biopsy, and if it's abnormal, what we look at is something called a Gleason score.
Okay.
And a Gleason score is basically when we look under a microscope, it helps define how aggressive these prostate cancer cells are.
Okay, so you can see that on the microscope.
Yeah, we define this score, and it kind of shows us how angry these cancer cells are. Are they low risk, meaning that they don't have the propensity to spread beyond the prostate? Are they intermediate risk, or are they high risk, meaning will they have a higher propensity or momentum to potentially spread? So the Gleason score ranges from 6 to 10. And so that we find out from a biopsy. Right. And so a Gleason 6 and a PSA of less than 10 is considered low risk prostate cancer. A Gleason 7 or a PSA between 10 and 20 is considered intermediate risk.
Okay.
And a Gleason 8 to 10 or a PSA greater than 20 is high risk.
Got it.
Okay. And so when it comes to their treatment options, their treatment options include possibly active surveillance or what we consider watchful waiting.
Okay.
So when we have a healthy male with a low risk prostate cancer where their propensity to spread is pretty low, sometimes we can just watch it. We just repeat their PSAs. Maybe their prostate cancer is very slow growing, and we do MRIs or repeat biopsies year by year.
It is year by year, not like 3 months, 6 months?
Yes, it is year by year. And they are being treated by what we call active surveillance. And so that basically is, we know they have a diagnosis, but it's a low risk prostate cancer, and we're keeping a very close eye on it. And active surveillance has shown to be beneficial for a lot of men, maybe if they have a lot of other active medical issues going on. Right. And so, and if the prostate cancer is slow growing, that may be a very reasonable option for them. Another option is potentially surgery. And surgery can be done either robotically or through an open radical prostatectomy. And basically what they do is they would remove the prostate and potentially some lymph nodes around the area. And the extent of their surgery would probably be based on what stage they are. Right. And how much spread is within the prostate. In terms of surgery, we do recommend surgery for typically with men diagnosed under 50. We usually try to push surgery on those patients because they're very young, and
the reoccurrence possibility?
Potentially, or just even their recovery. We want to remove the gland. The outcomes show that it's better in younger men because the prostate cancer tends to be more aggressive.
It's funny with a lot of cancers. I mean, the younger you are when you get it, the more aggressive it typically is.
True.
So I guess it goes along the same with the prostate.
Mm-hmm. And, you know, with recovery from surgery, it can be a little bit long. Patients can be incontinent, or it does take a longer time to recover from prostate cancer, but it is obviously a very vital tool for...
in their recovery.
Yeah.
And for a cure.
Yes, absolutely.
That is a lot of information for our viewers to absorb right now. So I think we're going to take a quick break on Welcome to Scan, and we're going to be right back after a few messages to listen to the rest of what Dr. Patel has to say. Great information.
Thank you.
Thank you, and we will see you shortly.
So, if you're over 65, like me,
and active and fairly healthy,
being active and healthy alone will not protect you.
Remember, the immune system weakens with age.
And if you're over 65, ask your doctor about your vaccination options.
we want you to be healthy and active.
Thank you for watching Welcome to Scan. We are here speaking with Dr. Patel about prostate PSA testing, different treatment options, and she is going to review that with us now if we all got a good understanding. And so there's high risk, low risk, and intermediate risk, and high risk.
Yes, so we previously went over when to screen for prostate cancer, how to test for prostate cancer, and once a patient's diagnosed, what are their treatment options. And we had divided patients up into low-risk prostate cancer, intermediate-risk prostate cancer, and high-risk prostate cancer. And for low-risk prostate cancer, we discussed briefly treatment options, which include observation, surgery, and radiation therapy.
Right, which all of those are well tolerated.
Yes, it has surgery has their different set of side effects than radiation. And so I'll speak a little bit more to radiation.
Right, well, that is your specialty, so we want to hear about radiation oncology and what's the specific radiation for prostate cancer and, how many treatment sessions they might have to undergo, something like that.
So radiation has come a long way in our field. So radiation's been used for prostate cancer for over 50, 60 years.
Wow, that's a long time.
And the average age for patients to receive radiation with prostate cancer is actually age 60. So men 60 and older are typical patients that receive radiation. And radiation is indicated for men with both low, intermediate, and high-risk prostate cancer.
Oh, so all three of them.
So all three of them, yes. And basically, when I see a gentleman with low, intermediate, or high-risk prostate cancer, their risk stratification will help guide me on what their radiation treatment options are.
Okay.
Because if I have someone with low-risk prostate cancer where I don't have to worry about spread of cells beyond the prostate, I have to just focus the radiation to that prostate. When I have someone with a high-risk prostate cancer, I have to worry about not only cells that are in the prostate, but potentially cells that may be in lymph nodes that are around the prostate, so my area that I'm targeting is larger. So based on their risk stratification will determine what areas I have to treat, and that will determine which technologies I use.
Okay.
So when I have someone with high-risk prostate cancer,
Right.
though I'm worried about the cells that may not only be in the prostate, but that may have potentially spread outside the prostate, such as lymph nodes. And usually we test patients, we do CAT scans and bone scans prior to them coming to see me. And the result, they may or may not also get something called androgen deprivation therapy. And what that is that will lower the testosterone in the patient's bloodstream because prostate cancer cells can grow with testosterone.
Right.
So when I have someone with high-risk prostate cancer, they are typically given androgen deprivation therapy by a urologist, and then they are given radiation therapy, which is typically 9 weeks, Monday through Friday. So it's about
that's a
40.
long
Yes.
time.
So it's about 44 to 45 treatments. And the reason being is we have to give a low dose per day. What radiation is just like an X-ray, similar to a chest X-ray, except they're slightly higher energy X-rays.
Okay.
And we take these X-rays and we have the technology to really pinpoint it to the areas that we want to target.
And it's pretty much a painless option of treatment.
Absolutely. So the nice thing about radiation is that it's outpatient and it really takes about 5 minutes a day.
Right, so they can be in and out.
So a lot of patients that, they'll walk in, lie down on a table, an X-ray machine will go over them, deliver the X-rays, they get up and they leave. It's typically painless. And the reason that it's so many treatments is because we're going slowly, giving us low dose per day.
Right.
And the low dose allows the cancer cells to die, but the normal tissues like your intestines or rectum or bladder to not get as affected.
So you're saving the other organs.
Exactly.
Which is very essential.
So for high-risk patients, that's typically what the number of treatments is. In terms of lower intermediate risk patients, a nice trend in radiation oncology over the last 10 years is something called stereotactic body radiosurgery. And even
That's
though
a long word.
Yes. And even though it has the word surgery in there, it is non-invasive, which is nice. And it allows us to give 9 weeks worth of radiation within 5 days.
Wow.
Yes.
So you're cutting down from 45 days to 5 days,
Yes.
even though your cancer now is at a different level.
Yeah, so for patients with low and intermediate risk prostate cancer where I can focus all the radiation only on the prostate and I don't have to worry about treating lymph nodes,
Right.
I can give a higher dose to a smaller area, and we have the technology to really do that now. And we have data for patients, up to 10-year data showing that the results are equivalent. So if patients
That
go
is
for 5 days
fabulous.
versus 9 weeks, the outcomes are the same. Side effects are slightly different, and but it is it's exciting times.
I was just going to ask you, so being in this field to see the progression on how, I mean, that must be like so mind-altering to you.
It
that
is.
you can make such a difference in such a short period of time now.
Yeah, absolutely. The technology, some of the technologies that we have now are, so it's nice that our hospitals within the Hackensack Meridian system all invested in these brand new TrueBeam linear accelerators. And what they are basically very precise modes of delivery to give radiation to a target, and they're fast and they're accurate. So we can line a patient up on a table, really pinpoint where the radiation needs to go, be confident that it's going where we need it to go, really minimize side effects, and really give a nice high dose as needed.
Right here in Monmouth County.
Right here in Monmouth and Ocean County, which is
Monmouth
really
and
nice.
Ocean counties, yes.
Yes.
Thank you for reminding me of that, because we are an Ocean County viewer. So,
Yes.
because years ago people didn't have these options close by here.
Yes.
So that's really a
Absolutely.
great benefit. So while we're talking about that, because a big word in this area of prostate is CyberKnife. Everyone wants to know about the CyberKnife. So tell us a little bit about what the advantage, maybe what exactly is CyberKnife and what the advantages are specific to prostate cancer.
Sure. So we spoke about 9 weeks worth of radiation for high-risk patients, and then potentially 5 days worth of
5
radiation
days.
in low and intermediate risk. And the way we can do that is by these machines. We have something called a CyberKnife. We have something called a Variant Edge in the system. And what these machines allow us to do is deliver that really high dose to a small, precise area.
Right, which is beneficial.
Yes. So the nice thing about CyberKnife is that it is a robotic machine. So believe it or not, the prostate can move within a centimeter in 30 seconds.
That's
So the bladder can fill in, pushing your prostate down. Gas or stool can go in the rectum, pushing your prostate up. And when we're trying to focus a radiation beam on it, we need to know exactly where it is at all times. So what the nice thing about the CyberKnife, for example, is that there's cameras in the room, and the cameras hone in on the prostate. And while it's giving the radiation, if the prostate moves, the machine moves with it. It's a robotic machine. So it's giving
fabulous.
the radiation to the prostate at all dimensions of rolling and moving. And so I can be confident that it's delivering a high dose exactly where it needs to be.
And it's getting the exact location.
Yeah, so that's the nice thing about some of these equipment that we have, that it's one thing to deliver the radiation, but you want to make sure it's going exactly where you planned it. And so there's variabilities each day to day with the positioning of these organs, and so we want to account for that.
And probably the prostate is the most movable organ that anybody's targeting.
Well, typically, yes, the prostate can move quite a bit.
Yeah, you just told us that. I mean, that's very interesting information. What are some of the side effects, and how do you track those side effects? Because, you know, people think they're going for radiation, they're in and out, but there are side effects that can occur.
Absolutely. So when we radiate the prostate, it will get a little inflamed, and so it will swell a little bit, and that will happen gradually. But because it swells a little bit, it puts pressure on the bladder or pressure in the rectum, near the rectum. And so those are the typical side effects associated with either CyberKnife or even 9 weeks worth of radiation. Because it's pushing on the bladder a little bit, the pressure, men usually complain of urinary frequency, urgency, they're getting up a little bit more
The
at
same
night.
as what their symptoms were with the prostate diagnosis.
Potentially. And so what I tell patients is we have to wait for that inflammation to subside, which it will, and the urination pattern should go back to what they were before they started. But there's so many different medications and different things we can do to help them get through those side effects.
Okay.
And rectal complications have really decreased in the last 10 years, 10, 15 years with all this new technology that I'm talking about, because we've really able to tailor the dose to the prostate and spare the surrounding critical structures like the bladder and rectum. So while the side effects are definitely can be present, they're much more reduced in how severe they are.
What they were years ago.
Yeah, so the nice thing about whether it's CyberKnife or other forms of radiation is that it's outpatient. Many men work during treatment.
Right.
There's really no recovery involved. And those are really, important factors for a lot of people. If they can't leave work, they don't have time off. A lot of the times they don't really have to disrupt their schedule. And
I mean, what a benefit that is, because, most men, they can't give up their jobs for 9 weeks to go get treatment. So that's really a great benefit. And are the hours
flexible,
for
absolutely.
the patient? That's what I was gonna
We're
ask.
open early. Most radiation departments are open early or late, and like I said, it typically, the side effects that can happen, usually after a few weeks, they start subsiding. So I tell patients, I joke around, I'm like, don't plan a vacation right after your treatment,
so-
but but maybe a month after, you'll feel back to yourself.
That is wonderful. Now, let me ask you this last question. Long-term results on the treatment, success?
Yes, it's a success. CyberKnife has been shown, 10-year data out there shows that it's equivalent to external beam for low-risk patients, and then we recently started doing it more and more for intermediate-risk patients, and 5-year data shows that it's equivalent to external beam. So the results are very promising. Side effects are very similar in terms of short-term and long-term side effects. And the way we track patients after they've had their treatments are basically we would, if they were diagnosed, suppose a patient comes to us with a PSA of about 10.
Right.
Okay. Then we typically will repeat their PSA about anywhere from 3 to 6 months after treatment. We wait for all that inflammation to subside, and then we repeat their blood work, and we would expect that their PSA would start trending downwards.
Trend
So
down.
maybe it would go from 10 to about 5. And
That's
then we would
wonderful.
repeat their PSA again in 3 to 6 months, and it would go down even more. So as long as the PSA is trending downwards, we know that they've had a good response, and we will continue to track them that way.
Well, you've given us a lot of great information today, and I have to tell you, it's been so comprehensive that I think our viewers are going to be probably ringing your phone to find out different when they can sign up if they have an issue.
Absolutely.
But I want to thank you all for watching. Welcome to SCAN. We are here with Dr. Patel, who just went over what prostate cancer is, different treatment options, and how to get your PSA checked and when to get it checked. If you have any future program ideas, please drop us a line at info@scannj.org. I'm your host, Tracy Wolfman, and until next time, thank you for watching.